So we're going to be starting this morning off a session on molecular markers in prostate cancer, covering both the pre-diagnostic and post-diagnostic spaces, and give you a sense of forward progress here. I do work with a number of the companies that make these markers. I have personal experience with almost all of them, and can give you some insights into that experience we've had. So starting in the pre-diagnostic space, I think it's really important, this gets to the discussion yesterday about what we need to do in the pre-diagnostic space. And my thought on this really has always been the PSA is actually the best marker in the history of oncology. It's just we never used it well. We tended in the 90s and 2000s to overscreen old, frail men. We underscreened young, healthy men. And then overtreated low-risk disease and undertreated high-risk disease. And this is a lot of what led to the 2012 task force statement that we shouldn't screen anybody ever. And another part of the problem here, of course, is that PSA does not have a threshold. And if it does have a threshold, it's certainly not at 4.0. 4 is probably the worst thing that ever happened to PSA as a screening marker. The reason we wound up with 4 is that the trials were done with older men with BPH. So if we use PSA better, if we focus on early baseline testing using a threshold, I'll show you at one point today, threshold should probably be 1, not 1.5 or 2, in terms of thinking about who might need potential further investigation. And despite all this, we drove down mortality rates 50%. So imagine what we could do with this venerable marker if we used it better. Now, of course, we do have lots more that we can now add to the mix. And at this point, the slide is I've been using the same slide and updating it now over the years, and it's getting too crowded to add all the existing markers. In the pre-diagnostic space, we now have 6 different markers that can be considered before a first biopsy. Several of these, as well as mpMRI and tissue, can be used to make a decision after first biopsy about whether to go on with the second biopsy. And these include blood, urine, and imaging tests as well. Imaging plays in the same space and needs to be evaluated by the same rules. And now, of course, we also have potentially saliva per yesterday's discussion. So again, we've got PCA3 in the urine, and more recently SelectMDx, ExoDX, and now the MyProstateScore. In the blood, we've got 4K and Phi, and then MRI, PRS. And all these need to be considered in a multivariable framework. Beating PSA is not really enough because we can already improve on PSA with multivariable calculators. This is the PCPT. There's the ERSPC, there's the Sunnybrook calculator, and others. I don't have a strong feeling which is the best, but these are actually very useful at the point of care. This is about the only website I ever go to in the clinic to pull up a teaching tool is the Smileygram, because I think it's a very helpful teaching tool helping patients kind of understand, well, this is your risk. And Ian Thompson, who developed this, made the comment, you can show the same 2 men a 7% chance of a high-grade cancer. One guy may decide to get a biopsy, one may decide not to get a biopsy. Those are both good choices as long as they are well-informed choices. So this is the bar. We do have a multivariable model to try to improve on. PCA3 alone, we don't hear about that much anymore, partly because it's incorporated in the newer markers, and also because it was never that specific for high-grade disease specifically. Our goal is not finding prostate cancer. Every man has prostate cancer if he lives long enough. The goal is finding the clinically significant ones. The other thing with PCA3, and one good learning from this is from a paper of John Ways at EDRN, is that the PCA3 was studied with various thresholds, 20, 30. It never really worked. It's no better than 4.0 for PSA. And the best thing about this paper, it looked at PCA3 with 2 thresholds. There's a low threshold below which it has a very good negative predictive value, a high threshold above which it has a very good positive predictive value, and then there's gray area in the middle. As this field has evolved, we've really focused now, I think, on the negative predictive value because the clinical role for these tests has really become trying to figure out who has a marginally elevated PSA and can safely skip the biopsy. 4K and Phi, I'm sure everyone's familiar with. These have been around for a long time. These are both looking at isoforms of PSA. They're both quite similar in their performance. This is actually one of the few situations where we have a pretty good head-to-head comparison study out of Sweden. And both of them perform quite well, better than a base multivariable model based on PSA alone. This is 4K, this is Phi. These curves are not statistically significant in terms of predicting any cancer or high-grade cancer. MyProstateScore is near the youngest on the market, although it's not a new test. This is an evolution of what was called the Michigan prostate score that Scott Tomlin's developed. It combines PCA3 with TMPRSS2 ERG in the urine. And you'll see most of the curves that I'm going to show you all look very similar for these tests. This is a decision curve. You're looking for improvement in net benefit, which is the true positives divided by the false positives, where the false positives are adjusted by this concept of a threshold probability. And that's basically the patient's willingness to be wrong. What's the implication of making a wrong decision based on the test, undergoing unnecessary biopsy, for example. So you want to see a lot of daylight here. You want to see these curves stay high across a whole range of threshold probabilities. So this is the PCPT calculator alone over just PSA, and this is the use of the marker. Again, works well for all cancers and for high-grade cancers. ExoDX, one of the more recent ones, once again PCA3 and ERG fusion. The difference with this one is it's looking at the exosomal component of the urine. So what this means pragmatically is this is the only urine test that does not require a prior DRE. That has not really been important until COVID hit, and we were trying to manage a lot of patients remotely, at which point, just for good timing, the company happened to have a home kit coming out around the same time. So we've gotten a lot of experience with this one because it was a great way of keeping people away from the healthcare system during the COVID lockdown era. And then finally, SelectMDx, this is looking at different genes, HOXC6 and DLX1, again, full-length mRNAs in the urine. This has been validated initially in large 2 centers in the Netherlands. There's a big validation coming out in the VA system as well. And like the others, this improves over a PCPT-based multivariable model alone in terms of both AUC and decision curve analysis here. And like the others, this one has really been sort of calibrated for a high negative predictive value. The goal is if this test is read as negative, it's a 98%, depends on what exactly is on the report, roughly 98% chance of not having a high-grade cancer. The assumption being that if you've got a Gleason 6 in there, we don't care. And that is a very, I think, an increasingly safe assumption to make. Now, where do we use these, and how do we use these vis-a-vis MRI? So the negative predictive values for these, like I was just alluding to, are pretty good. The 4K is right on a continuous score. You get a % likelihood of high-grade cancer. But they give you a threshold around 7.5% over which they recommend biopsy. SelectMDx and ExoDX both have these very high negative predictive values. What about multiparametric MR? Well, it's only 76%. Now, this is from the PROMISE trial, which is the best source of data for negative predictive value. But to be fair, they were doing template mapping biopsies here, so they found a lot more high-grade cancer in this trial. Now, again, we've been using the home kit for Exo a lot, just as an aside. But just to spend 2 more seconds on the MRI versus liquid marker first question, these are data from Stanford, just down the road from us at UCSF, very good MRI shop. Depending on which radiologist happens to pull your MR, the positive predictive value of a PIRADS 5 ranges from 40% to 80%, depending on which radiologist at Stanford University pulls your MR. This is not acceptable if we're going to use this as a secondary screen in community care. The UK, they are running a trial of MRI first, no PSA. Doesn't matter what your PSA is, everybody gets an MRI. In the UK, it costs about $300 to do an MRI. Here, of course, it's 10 times that. But the PIRADS 2 system is just not there. This is a great meta-analysis of a number of different, mostly academic center experiences. Again, it's focusing on a positive predictive value here rather than the rule out. But 25 to 75% positive predictive value for finding high-grade disease with a PIRADS 4 or 5 across major academic centers. PIRADS is not there if we're going to use this in broad practice in the community. So, how do we sequence these things? Well, we can use PSA, then MRI, then biopsy. We can use PSA, then a marker, then a biopsy. We can use a marker to decide whether or not to get an MRI and then do a biopsy. We can flip that order, or everybody can get a marker and an MRI. And look, all these are fair game. The one that we use at UCSF mostly looks something like this. We are encouraging very low threshold PSA referrals. We get markers quite liberally. We probably have the most experience these days with Exo and 4K, but we've used SelectMDx a lot over the years as well. And then if the marker's high, we get an MRI, but we get an MRI to guide the biopsy, not to decide whether or not we're going to do the biopsy. Sometimes if the marker's borderline and the MRI is negative, we will use that as a rule out, but that is not the most common scenario. So PSA screening, low threshold, liberal use of secondary testing, and MRI to help guide what we do. These tests the liquid tests have very good negative predictive value, and I think can even be considered for reflex use in primary care. And we're starting to talk about a design like that at UCSF. Briefly on post-diagnosis, very similar statements here. We had a consensus statement conference at the AUA a few years ago. And just like the liquid tests for pre-diagnosis need to improve on more than just a PSA, a post-op test needs to improve on more than just a Gleason score. And it's got to improve on more than just the NCCN risk groups, which are completely outdated at this point. You really need to improve on a multivariable model. And we can do this, so the risk groups, I won't belabor this point, but the very low risk group in particular has just no relevance today. In the era of targeted biopsies, it's basically impossible to find somebody with only 2 cores positive, no more than 50% of a core positive. It's become a completely irrelevant categorization, and the whole debacle about preferred for low risk really had a lot to do with how antiquated the very low definition is. This is an obvious statement here. These patients are both favorable intermediate, despite having very different clinical criteria. We can pick this up with a tool like Capra or with a nomogram, but the risk groups just aren't cutting it. And because we can do this already for free with a real multivariable tool, saying that we could divide these patients with a biomarker doesn't necessarily justify spending a few $1,000s. So we got to improve on a true multivariable model, which most of them do, by the way. It's just the way the reports are formatted that kind of cheapens their value. And there is a comment in the 2018 U.S. Preventive Services Task Force that we cannot distinguish indolent from aggressive prostate cancer. It is utter nonsense. They haven't read the literature. This is, I don't know what else to say. This is the Capra score. There's many other ways to do this. C-index 85 is 85% accuracy in separating low from high risk disease out to, this is now in capture, out to 15 years, risk of mortality from basically 0 to more than 50%. This is the basic clinical information alone. And we can do even more for free with things like PSA density, how much pattern 4 is in there in the Gleason 7s. Now we're subtyping pattern 4s into cribriform, expansile cribriform, et cetera. So the bar is actually pretty high to prove that you can do even better with a relatively expensive tissue test. Now, of course, those tests are passing that bar. These are the ones that are clinically available now. There's nothing really new on the market here recently. It's still Prolaris, Decipher, and Oncotype. These are all tissue-based tests. I'm sure you are all basically familiar with all 3 of these. Do they improve risk prediction? The answer is absolutely yes. All 3 of these tests has been shown to improve on a true multivariable model. Either Capra or some of them built a brand new de novo model. They've done this on the nomograms in some cases, and they work. Slightly more recently, the Prolaris score. One of the things I like about the Prolaris platform is they integrate the genomic information the most formally with the clinical information. So they have this CCR score, which is clinical plus genomic risk, and they're doing this at the individual variable level. And they now read this out with a threshold of 0.8, and if you're below this, basically nobody has progression out to 10 years. Now, of course, 10 years is not necessarily enough follow-up, but still, if you're looking for a threshold in use of a genomic test, this is one of the better presentations of a threshold that I think I've seen in this space. The GPS score, and just for someone who's familiar, the Prolaris score is really focused on cell cycle progression, so how fast the cells are turning over. The GPS score was the second on the market. It looks at 4 different pathways. This is really intended to predict adverse pathology at time of surgery for those who had what looked like low-grade disease at diagnosis. And it does this well. It will shift predictions both up and down pretty consistently. About 50% of patients have at least a 5% shift in either direction when adding the genomic information to a multivariable clinical model. And finally, Decipher. This one is by far the best validated at this point. There are dozens of studies out. This is a meta-analysis that came out last year. And basically for any endpoint, this is adverse pathology, BCR, metastasis, biochemical failure, after radiation, and prostate cancer-specific mortality. For every endpoint, it works and does tend to beat standard of care. There's different standards of care in these different studies, but it works pretty consistently. Now, do they improve decision-making for active surveillance versus treatment? Here, the question is much less crystal clear. The data are less clear. There are studies out there on clinical utility. Some are done better than others, but it's not clear how often the decisions are in the right direction, and certainly nobody has shown that we're improving outcomes. And part of the problem is that a ton of science goes into the development of the markers, and then, for better or worse, the reports are generally produced by the marketing departments, and we wind up with a lot of numbers and pretty complicated reports in some cases. The patients are already hit with all these different numbers. Now we throw a Prolaris score, an Oncotype score. What do they do? I would argue most of the time we don't know what to do with these either, and part of that comes down to the presentation. And I'm not in any way intending to beat up on the Oncotype here, but specifically, but because these tend to be formatted in terms of the NCCN, you can get these crazy scenarios where the guy on the left clearly has This is a higher genomic risk tumor. It's a higher volume tumor. He's got a higher Kappa score, higher PSA, et cetera, but he's called low risk, whereas the guy on the right, despite having a lower GPS score, lower volume, everything's lower except for the fact that he started off, gleason grade group 2, he gets called unfavorable intermediate. This guy's rushing to treatment. This guy is feeling safe about things, and that is not necessarily correct. And I think there was a comment the other day that everybody wants a pregnancy test with these, and that's just not the way, of course, the biology works. And a final point here, when we think about post-diagnosis, don't forget that in the PIVOT trial, for all its flaws, prostatectomy versus watchful waiting based on a sextant biopsy and no further investigation, there was absolutely no difference between these curves for low-risk patients specifically. So we need to be a little bit careful about how hard we are chasing we're chasing patients who are low risk looking for higher grade disease. So just to sum up the second part of it, markers absolutely do improve prognostic accuracy over a true multivariable risk tool. Who benefits, who we should use these tests on, I think that is still in evolution. I'll talk about that a little bit tomorrow. Future role really should help men actually tailor the intensity of active surveillance as well as just who should go on surveillance. Again, we'll talk about that a bit more tomorrow as well. And finally, these tests need to become predictive, help us guide actually what to do, not just tell us which cancers are worse. So it's an exciting time to be at the end of the beginning of the story, and look forward to further developments.